Nick Majerison here. Welcome along to Top Med Talk. And it's time for a brand new series here on Top Med Talk. It's Tripom, trainees with an interest in perioperative medicine. They're reporting from the Ebpom USA Dallas Masters course, Perioperative Care Practicum, which happened, of course, in March of this year, March the 22nd to the 24th. Make sure you check out ebpom.org/meetings to find out more details of meetings that are being arranged around the world as part of evidence-based perioperative medicine. ebpom.org/meetings. In the meantime, let's have a listen to Tripom.
Top Med Talk.
We are back. Tripom, trainees interested in perioperative medicine. I'm Rob.
My name's Bridger. We're both Duke residents from Duke Anesthesia.
And that's in North Carolina for the international folks who don't really know geography of the states. And we're sitting with Dr. Mike Grant, who is a cardiothoracic anesthesiologist from Johns Hopkins, and he is going to tell us about some cardiac ERAS. Dr. Grant, please introduce yourself. Tell us what's going on.
Thanks, guys. My name is Mike Grant. I'm from Baltimore. I've grown up my entire life in Maryland, and originally, believe it or not, thought I was going to be a cardiac surgeon. Actually matched into cardiac surgery.
But then you saw the light.
That's exactly how the story goes. And there was a girl involved.
Ah, of course.
And the long story short is I did end up doing cardiac anesthesia, and I also tacked on a year for critical care. So I wear both of those hats at Johns Hopkins. And I'm pretty involved in some of the enhanced recovery stuff that's going on there as well.
Fantastic.
And that's what we wanted to talk about today, because there's been some talk about cardiac ERAS, but it seems like a lot of it's still kind of a mystery, at least to us. So we wanted to ask you...
You're not the only one.
Well, please enlighten us. We wanted to ask you, how do you standardize the care in patients with such extremes of physiology?
Yeah, so I think this is actually where this conversation should begin. I think first and foremost, one of the things that has been a bit of an error, not grandiose error, but an error nonetheless, is trying to take all of the elements that we have from some of these other service lines, colorectal being the hallmark, and just kind of picking them up and dropping them into a cardiac bucket. And I think the mistakes there are kind of what you're describing, is that we're talking about an inherently different patient population here. It's not uncommon for these patients to be coming in with primary ischemia as their reason for being in the hospital, and they're going to be intolerant to some of the things that you might expect from the colorectal pathway. But then within cardiac surgery alone, as you mentioned, we have this large spectrum of patients that go anywhere from that kind of 50-something-year-old who incidentally found this issue to your kind of very, very old, aortic stenotic patient that is just, again, inherently different from that other spectrum. And so I guess the real question begins on, do we approach these as uniquely different populations? Do we, speak to the baseline and try to, establish some of the small foundations and then build up on those? And the short answer is we don't have those data yet. So in some sense, this is a well-intentioned movement that's in its, infancy, and we have to discover some of these things together.
So where are you actually beginning when you're taking these different pathways, modeling them, and obviously adjusting them to the cardiac world? Where do you begin? Do you throw the whole kitchen sink at them, and then start piecemealing and adjusting things as you see outcomes in the ICU afterwards, or where do you start?
Right. So good question. So I'll tell you where we in general have started, and we being the ethereal we. The very first examples of cardiac anesthesia, and I'm using air quotes right now, were to take colorectal principles and just ad hoc, throw them on. And I don't think that was entirely ill-advised, because some of those things are transferable. However, I think there are certainly things that we have some controversies around. So if I was going to begin, and we have begun at Johns Hopkins to do some elements of this, I would go back to the literature and I'd say, what are the key features around cardiac surgery that are inherently different than these other service lines? And let me speak to those key features. And when I'm establishing a protocol, make sure that I've spoken to those key features regardless of what it is I've tried to install. I think you can be thoughtful about certain things in colorectal. The idea of applying a multimodal analgesia approach, for example, that seems inherently correct regardless of what service line you're kind of talking about. But when you start to talk about some of the other features, things like carbohydrate drink at the beginning of a procedure or some of the prehabilitation elements, I think some of these require a more thoughtful discussion. And before you ad hoc toss them all into the bucket, I think what you really have to do is go back and make sure that you're really talking about the specific things that are inherent to cardiac surgery that can't be addressed by these other service lines.
That sounds like quite a difficult task.
Mm-hmm.
And I'm curious to know how, this isn't something that anesthesia or critical care or one physician can take on themselves. You need to have buy-in from the surgeon. How is that going? How do you approach that? Are they interested? Is there literature out there to convince them that this is a good idea? Where do we begin that conversation? How does it go?
Yeah. So I think there's a couple of streams that have come together here that have been uniquely beneficial for us locally at Hopkins. One of those is that we had, I think, a fairly large turnover in our surgeons within the last couple of years. And what that allowed us was an opportunity to establish a new surgical cohort that really believed in this concept, that they believed that there was maybe not a better, but definitely a different way for us to be managing these patients. And I think that's kind of where you start that conversation, is that you don't approach surgeons and say, hey, by the way, I've got the special sauce. What you've been doing for the last 30 years doesn't have to be right. That's not a good conversation to start with anybody. And in fact, what we found in our own institution is that some of the biggest resistance was even from our own anesthesia colleagues who had been doing this forever and been doing, by the way, a really good job at this for a long time.
We're so resistant to change. It's unbelievable.
Think about it. If you've been doing this for decades and you have, ascended the ladder at your institutions and you're really kind of at the front edge of what you're doing from an anesthetic or surgical standpoint, I can understand why you may not want the young guns to come around and start deciding how you're going to manage your patients.
Sure.
But back to your question specifically, I think one of the easiest ways to really sell this concept to surgeons is to say, I'd like to offload you. I'd like to make it so that you can focus on the things that you do exceptionally well. I want you to be an excellent intraoperative technician. I want you to manage your patient's expectations throughout the entire perioperative spectrum. But I want you to be offloaded from those key elements that you don't need to have formal training in. I want to take over respiratory therapy from you. I want to show you how nutrition can be optimized. Let me have the anesthetic and analgesic plan. And I think in some ways what you're offering there is for them to really focus and hone in on the skill sets that they were really trained to do initially and, allow for these other pieces to be taken off of them, reduce the burden on them. Then the other piece that I would also say is that all of these surgeons are competitive in their inherent nature. And so if you can show successes in these other service lines, or now that we're starting to have early data in cardiac ERAS specifically, you're going to start seeing the competitiveness come out of them, and they're going to want to see how they can continue to optimize their own service lines. And so I think regardless of how you want to start this conversation, I think it will happen eventually. But these are some of the tidbits that I'd offer.
So out of curiosity, what role do you think there is for prehabilitation, patient optimization? How much time would you allot for this?
Yeah. So, the data on this is a little bit mixed, and I'll admit that, some of the data that we have are really specific to key pieces of prehabilitation. Things like, can a person tolerate a certain distance walking, or can they, improve their pulmonary status based upon a number of different pulmonary tests? What we believe now is you probably need 4 to 6 weeks before surgery if you want to take a person who is suboptimized and truly optimize them.
And this patient population is unique in the sense that sometimes you don't have 4 to 6 weeks. You have someone who comes in with, critical ischemia. You're not going to put that off. Or maybe we should. I don't know. So
I think that's an excellent point. And, again, this is where you're speaking to the fact that we've got several different types of patients that are undergoing these procedures. It's a little bit akin to the concept of colorectal, elective colorectal and emergency colorectal surgery. We do, by the way, have enhanced recovery for emergency colorectal surgery. They're finalizing these guidelines on an international basis right now. So this has been done before. It doesn't mean that we have the solution necessarily in cardiac, but it's definitely a roadmap for how we could start to have that conversation. But one thing you spoke to, which I think is really important, is that there's a culture for us to bring these patients in, have them in the hospital the night before, go to surgery the next day. And I think there are many reasons why that may be the case. It happens to be one of the few money-producing procedures that we have in a hospital setting. And so for that reason, when you have an opportunity to have a patient in your hospital, you grab them and you take them. So this would require a very significant cultural shift. We'd have to start explaining and really showing the evidence behind how a delay of 4 to 6 weeks and the potential loss in revenue will truly benefit that patient and, frankly, lead to improved revenue on the back end. And that's a model that it will be incredibly challenging for us to produce.
Gotcha. Would you be able to maybe fill us in and the listeners to our program, some of the other trainees around the world, what are some of the big implementations that you guys have started to do at Johns Hopkins for your ERAS?
Yeah, so it's a great question. So at Hopkins, what we did was we decided to do what we're calling a phased rollout. So what we did was we identified the individual buckets, so the preoperative, intraoperative, postoperative buckets. And we decided that we would tackle the one that I actually felt would be the hardest, which was the intraoperative component, and we'd do it kind of all en bloc. Mm-hmm. And so what we decided was we'd take our entire anesthesiology group, we'd come to some consensus around how we wanted to manage patients, both in that real initial preoperative bundle, that kind of medication bundle on the PACU, and then the intraoperative anesthetic itself. And so what we did was we went back to the literature, we took a look at what those elements probably could or should look like, and then, again, drew consensus among our group, had buy-in from the surgeons that this was the direction we'd take, and then we really installed this kind of intraoperative component. The results of this will be actually coming out soon in publication, but the short kind of conceptual framework around this is that we really wanted a goal-directed anesthetic. We wanted an anesthetic that, again, this is somewhat counterculture, the anesthetic ends at the end of the surgery. So we really targeted short-acting anesthesia maintenance. We targeted multimodal analgesia. We target opioid-sparing techniques. We do a new regional component. And we extubate, it's our goal to extubate patients in the operating room. So this has been a massive paradigm shift from where we kind of initially were, even as recently as about 2 years ago.
Really? And when you're the goal to extubate intraoperatively, that's not slowing down productivity or anything like that. You guys
this is the question, right? So this is the age-old question. So the short answer to your question is that, frankly, at the outset, it did slow productivity, because if you're thinking about it, you're really teaching people who've been doing this for a long time how to add in several new components to their anesthetic and then tailor it in a way that allows you to still improve the kind of throughput.
Sure.
And for us, we did see delays initially. So, we do a serratus anterior block, for example, at the end of cases. And I can outline a couple more of these things. But that adds a delay because we're not only having to do the procedure, but we're also having to in-service clinicians on how to do this procedure. And so that's requires a certain time element. The extubation itself, we've gotten pretty good at it over time, but initially, remember, what we did was we started to learn how to extubate again in this case, and so that's a process. I'd say over the course of about the 18 months that this has been live, we've gone from having pretty substantial delays to, I would argue, it's just as quick as we were at the outset.
That's fantastic. So you've reinvented the cardiac anesthetic, it sounds like.
Well, I think, that's I don't want to take those words, but I will say this. I do think that we are forcing the edge a little bit on this. A couple things that are definitely unique. We've taken our opioid, again, these are data that'll be oncoming, but we have taken our opioid requirements from, a full stick of, fentanyl for a case. We're using usually around 100 to 150 mics of fentanyl for an entire case. And that's opioid-sparing strategies that are not translated to the postoperative. So it's not as if we spare opioids intraoperative and the patients get a ton of it postoperatively. It's actually coincided with the reduction in opioids postoperatively as well. Like I said, we're using regional technique in a cardiac setting, which is something relatively brand new. And our most recent data from our last 3 to 4 months has been that we extubate upwards of about 35% of our patients intraoperatively, and nearly 85% of them are extubated within 6 hours. And so these are all substantial gains that we weren't enjoying at the beginning of this program.
Are you seeing a decrease in ICU stays as well?
So the short answer on ICU stays is I doubt it. We have data that suggests that we are not, and the reason that I don't think that we are is more a systems issue. If you think about it, it's a perfunctorily one-night stay in the ICU, so it's pretty challenging. What gains you'd make would be in the matter of hours. But what we are seeing are actually reductions in length of stay down the line. So patients who are extubated in the operating room actually enjoy a much shorter length of stay, and this is propensity matched data. So we're actually seeing about a 20-hour reduction in length of stay for their hospital stay on the back end of this. There are many reasons why this may or may not be the case. You could argue that patients that are able to tolerate this and are able to be extubated may inherently be less sick patients. And I think that's a reasonable argument. But again, we did our best to try to propensity match these patients in a very concerted way, and we're pretty convinced at this point that there's something around this idea of uncoupling the extubation from the ICU, this requirement that a patient needs to have some cool-off period, and allowing that patient to then have subsequent elements happen much more quickly. And I think, again, we're seeing patients are starting to make gains on the back end of their stays as a result.
It's pretty impressive results. You mentioned that you do some pre-medication for the patients. You do some regional anesthesia. What other opioid-sparing strategies do you guys employ? Like if someone wanted to replicate something similar to this, what would you recommend to them?
So I'll just give you the full cocktail. So what we start with is a pre-medication bundle that includes gabapentin and Tylenol. So it's about 600 milligrams of gabapentin, about a gram of Tylenol. Intraoperatively, we use a combination of a ketamine infusion. We run that at around 0.25 to 0.3 milligrams per kilo per hour. We use Precedex in the operating room for every case. I'm pretty aggressive with my Precedex dosing. I'm usually towards the max for the first couple hours of the procedure, just because that's the more caustic portion. And then I back it off a little bit because I'm intending to extubate the patient at the end. We'll redose Tylenol if, God forbid, we're in there for 6 hours, which in an academic setting, as you may be able to attest, it happens more often than we want to admit. And then, as we mentioned, we're blocking them. We use serratus anterior blocks at our hospital. We've worked on things like PEX2 blocks and some other options as well. I'm pretty happy with serratus anterior so far. And then also importantly, we run the Precedex infusion postoperatively as well. So extubation or not, they stay on Precedex for a handful of hours afterwards. And again, with all of these strategies, we've been pretty happy with the results. It's led to substantial reduction in opioids and no change in our pain scores. So our pain scores are still 100% stable throughout the entire program. So again, we're pretty encouraged.
That's tremendous results. Has prescription opioids decreased by surgeons when they're releasing from the hospital? Is that translated to...
I love this. So you're teasing out kind of the back end of what we're looking at now. So we've just started to look at this problem. And what I'll say is that the early returns on enhanced recovery have actually probably given us an indication that unless you marry that opioid reduction strategy with a pretty thoughtful prescription practice, you're not going to make those gains. Because what will happen is, you'll have a provider on the back end, a well-intentioned provider, give them a big script and then not a lot of education around that and not a lot of follow-up. So for us, what we've decided to do is we're going to look at their last 2 to 3 days worth of hospital opioid requirement and then extrapolate that out and give them a week-long prescription. If they need something more than a week, then they've got to come back in and we've got to talk about what the problems are. And our experience has been so far, and this is early data, that it's been pretty encouraging. One of the other things that we're actually in the midst of getting out to publication is that we've found that in cardiac surgery writ large, about a little over 8% of patients after CABG have persistent new opioid use afterwards. So at 90 to 120 days, they're still taking opioids for this procedure. That's pretty comparable to some of the other procedures we've seen, and for the longest time we had a belief that cardiac surgery wasn't one of the big contributors to this problem. Turns out it actually is. In fact, it's probably squarely within the error range of all the other procedures. So again, to your point, we've got to start coming with strategies to reduce that.
While we've been here at this great conference over the last 2 days, there's been a lot of talk about methadone and its use intraoperatively as a potential dose up on induction and then nothing else and then use as a post-operative rescue in the PACU. Any thoughts of including that in the cardiac ERAS? Is it necessary, unnecessary?
So I like this question, and the reason I like it is because we thought for a long time about using it ourselves. And in fact, we did a mini kind of trial, more of a feasibility trial with it. I think there's two issues with methadone. The first is it's very unpredictable. Our experience has been that PO or IV, whichever form you give, I don't think that you can predict exactly what the duration of that effect will be. And it's particularly problematic as the patients get older, and as you know, our cardiac population tends to be on the older side. But I think the other piece that was problematic for us was that what we're really trying to do here is get patients extubated immediately. We want the case to finish and for the immediate de-escalation into support to occur. So we felt like, and this was something we started seeing in practice, that methadone was really impacting that ability to do it. Patients probably were able to breathe reasonably well, and I'm not really concerned about the respiratory depression portion of it, but they were altered. Their mental status was definitely altered. And those trials that we've described in cardiac surgery didn't look at things like 6-hour extubation rates. There's one that did say that it didn't impact 8-hour extubation rates. That's in anesthesiology. And again, that's in the setting of a fair amount of opioid use. So my question really is, if we are using much, much less opioids, does our patient population really fit the same description as the ones that were captured in that study?
Sure, especially with, you bring up a good point about, delirium and cognitive decline. I mean, this is a major procedure. That's high risk for these elderly patients to have cognitive dysfunction afterwards, and adding methadone onto something like that is just a confounder. And we don't even understand. We're still learning to tease that out, what is going on with cognitive dysfunction in anesthesia and surgery.
So I think that's a great point, and that's something that we've started to take a look at ourselves. Charlie Brown, who works a lot with Miles Berger, and is one of the leaders kind of in the postoperative cognitive dysfunction in cardiac surgery, has some strong opinions about this, and the data bears out that fewer medications, especially medications that are the ones that are unnecessary, really should be kind of carved out. And so far, for us, methadone meets the standard of one of those medications. That said, I also could make the argument that we have introduced a number of medications here as well. And so some of those, although had initial promising results for things like delirium, i.e. ketamine, the more recent data has suggested that ketamine may not be kind of the smoking gun to kind of cure all postoperative delirium. So I think there's a lot of work to be done in this area, and I might make the argument that the more we try to push to get patients awake earlier, the more likely we are to see kind of gains from that cognitive standpoint.
Another important and often talked about component of ERAS strategies is fluid management, and I think this is particularly difficult to do in cardiothoracic surgery for a number of different reasons. When we talked about the physiology, but also the anesthesiologist isn't the only person giving fluids during the case. The perfusionist can do that as well. What have you guys implemented at Hopkins?
Yeah. So I think these are two kinds of questions, but they're interrelated. So we'll start with perfusion, because perfusion really for everybody is this big black box that's kind of happening in the side of the room, and everybody has a different strategy, and there's a number of different medications that are thrown into the pot. And things like whether you wrap a patient or whether you ultrafiltrate a patient, they have major implications. What we did was we started basically the same way that we started with our intraoperative protocol, and we said we need something more specific and more consistent. And so we sat down with the perfusionists. One of the leaders of this from our side was a guy named Slava Borodka, and he created a goal-directed perfusion protocol along with the perfusionist team. And the way that this works is that you focus on delivering a certain amount of oxygen at all times while you're on bypass. You focus on a certain blood pressure goal, and you achieve that in a very specific way. We really limit the amount of wrapping that we do. We really limit the amount of ultrafiltration we do and hemoconcentration. And those strategies have led to a substantial reduction in acute kidney injury. That's something that he's published on previously. And again, we think that it marries well to this concept of how are you managing your goal-directed fluids. A goal-directed fluid, and again, I'm using air quotes here again, is kind of moving target. Because I would make the argument that despite all people's well-intentions, we still don't have a real great algorithm for this in any surgery. I think that the inception of some of these fluid monitors has been helpful, but I also think that they're not perfect. And particularly in a cardiac patient where you may have a failed pump as a mechanism for this, those algorithms are different. And I can't tell you specifically how they're different because those data don't exist. And so I think to your point, one of the moving targets in where cardiac ERAS is and will be is how do we manage fluids in those patients. Right now, the only thing I can tell you is that, to be as well-intentioned as possible, you shouldn't be too far on the left, meaning you don't give enough, and shouldn't be too far on the right where you give too much. And I know that that's a terrible answer, but genuinely, that's what the data show us right now.
I think that's, we've heard quite a bit about that.
Yeah.
Yeah. If you were going to, you're talking to trainees right now. What 3 things could you tell them that they could be doing during a cardiac case to help better their outcomes on their patients? What 3 major points would you recommend implementing in their practice now?
Yeah, so I think this is great. I would say the things that I have found to be the single most impactful elements are multimodal analgesia. And that means pick 3 to 5 things that you can add to this patient that are non-opioids that can improve pain scores and reduce that opioid burden. Reverse your paralysis at the end of the case. It doesn't matter whether you're going to extubate or not. Just reverse the paralysis. We use Sigamidex, but that's not what needs to be used. And the reason I say that is because what that really does is it gives you an opportunity to really evaluate that patient, not only for extubation, but for everything. That patient then, all of a sudden, that anesthetic has a different look to it. Your requirements for things like sedation have a different requirement to them. And regardless of whether they're bleeding or have hemodynamic instability, the decision to reverse a patient fully at the end of the case has almost no implications. So that's 2. And then the third one, and I'm going to cheat this one a little bit, and I'm going to cheat into the people who are actually caring for these patients in the ICU. Get the patient out of bed right away. Mm-hmm. So as soon as you humanly possibly can, get them out of bed.
Get them up, walking around.
Get them up and moving. And they're going to be a little irritated with you, and that's okay. But it's a little bit of a tough love in that first 12 hours or so. But for me, the real crux of this has been the anesthesia ends at the end of the case. You get the patient extubated, you get them out of bed. Those are the 3 things that I think as an anesthesiologist we can make the biggest impact.
So aren't there a set of guidelines that are going to be coming out in a month or 2 from, the ERACS, the Enhanced Recovery After Cardiac Surgery Society? Like, there's some guidelines coming out, right?
Yeah, so, ERAS Cardiac has worked on this for some time now. The teaser is that they're anticipating that their formal recommendations will be published probably in the next 6 weeks or so. And what those will do is they'll give an outline of where we have true data for some of the elements for cardiac surgery. And they're going to talk to things that are preoperative, intraoperative, and postoperative like any of the other enhanced recovery guidelines. Importantly, what they'll also do is they'll tell you whether or not we have good level of evidence for these things. And so those are the key features, not only the recommendation, but whether or not the level of evidence kind of meets the standards that they'd hope that it would. And I think that what it'll really tell us is where can our efforts really be placed going forward to try to either improve some of the elements that are kind of low yield or give opportunities for further exploration. Where can we start putting dollars for things like research to try to impact the pieces that have the lowest levels?
All right, well, looking forward to that. 6 weeks.
Yep, and don't forget to check out erascardiac.org to learn more, to be looking for those guidelines coming out in 6 weeks. And Tripom, thanks everyone for tuning in. It's my pleasure, Rob, and
Bridger, and Mike Grant. Thank you for joining us.
It's been a pleasure, guys. Thanks very much.
Thank you.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done. And it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about Ebpom London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that Ebpom organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.